Hi there, my name is Amy Jensen, and I am a second-year student in the Masters of Communications Disorders program here at ASU. I hope when I graduate to be able to work in early intervention with children ages 0 to 3 and their families. And Dr. Patton has asked me to share some thoughts for the language impairment in children lecture. So let's get started. So when we start talking about language impairment in children, it's important to first kind of discuss the modalities or aspects of language and components of language that we use to categorize or describe the strengths and weaknesses that we might see in a particular child's pattern of language impairment. So we will look at both receptive and expressive language. So receptive language is everything we hear, understand, comprehend. So that's everything going in, right? And then expressive language is everything coming out. That's what we say, speak, express. And then we also look at different modalities of language, say oral versus written. So that's, everything we speak and hear, but also everything we read and write. So we will look at patterns of strength and weakness in those modalities as well. We also look at the components of language, and that's referring to form, content, and use. So if you haven't heard this before, don't worry, you're going to hear it a lot as you go through the program. But form relates to syntax, morphology, and phonology of language. So this pertains to word order. It pertains to little units of meaning, like word endings, plural S, possessive S. The speech sounds of the language, that's phonology, and how they relate to each other and patterns of use. Also, there's content, so that refers to semantics, and that is word meanings, how words relate to each other. And then last of all, there's use, and that is more the social aspects of language or pragmatics. So that's conversational rules, social rules, maintaining the topic of conversation, matching the language to the situation. So those are all pragmatics. So when we look at children with language impairment, we'll look at all these kind of dimensions of language, and then we'll describe where we see strengths, where we see weaknesses, and that then allows us to maybe capitalize on those strengths to start addressing the weaknesses. So also before we begin, it's important to note that we should be pretty well familiar with typical child language development. I think you're going to have a lecture on this if you haven't already, so I won't dive a whole lot into this. I will make mention of what's typical so we can kind of compare it to what's atypical. But I just want to point out that the stages of language acquisition in children are kind of a big bucket, right? They're not necessarily these discrete timeframes that we sometimes think of, like babies have to speak their first word by 1 year. It's kind of more 9 to 15 might be normal, but maybe if they're on the 15-month end and then they've also got a few other red flags, then that might be concerning. So of course it's always context-based, but the point is these developmental norms that we're aware of in children can span a somewhat broad range. But we do know the norms, we know the order of acquisition. And so as professionals, it's important for us to be able to know those, to understand the norms associated with each stage. And when we do, we're able to discern when a child's language development is falling outside that norm. Also, it's important to note that children do make errors as they're learning language. So an error does not necessarily a disorder make, but our job is to be able to parse between what's typical and atypical and get children the help that they need. Okay, so before I move into this, I am going to kind of go a bit through chronologically, beginning with infants and going through school-age children. But I also want to direct your attention to the PowerPoint slides. So in the notes section of the PowerPoint slides, I do have links to videos that I'm not going to have time to share today. So I just wanted to point that out before I forgot. So if you have the opportunity, you can cut and paste those links into your browser and get kind of a sample of what some of these stages of language acquisition that we're talking about should look like typically. And then I've got some, I do have a couple of videos also that demonstrate atypical language. So take a look at those because it can be kind of informative. Okay. So beginning with infant language development, this starts with what we call the pre-linguistic stage, because babies, of course, don't have language, but they're acquiring speech sounds. And speech sounds are kind of the fundamental building blocks of language, right? So beginning with infants, we take a look at their stages of vocalization development. And I have the list here as was described by ODDLER. I think you're going to hear more about this in another lecture, but one thing I'll quickly note, I know this convention right here looks a little strange, but just to kind of orient you to it, it's year, semicolon, month. So this is referring to 0 to 2 months, 2 to 4 months, 4 to 6, etc. So the stage that I want to kind of point out to you is this 6 to 10 month stage where babies should be producing some sort of canonical babbling. So what that is the ba ba ma da 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 ga 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 kind of sounds that we associate with babies typically. So these are repeated consonant vowel syllables. They can be reduplicated like ba 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 ba, or they can be variegated like ba mi. So, but at this point, they're not necessarily communicative. These are just speech sounds. They're just practicing. But what's important about this is that if the child does not acquire a broad enough speech sound inventory, then when it comes time to start learning words, they don't have those building blocks for the words in later language. So speech sound development is important to language development as well. Okay, so other things that we watch in infants, we look for eye contact because that's an important part of communication and learning language as well. We look at their ability to establish joint attention. That's sharing focus on an object with a caregiver or partner. That's reading a book together, playing with it, looking and playing with a toy together. And we look at their gestures. Are they using reaching? A little later on, they start to use pointing. Object use, symbolic play. Symbolic play is probably more like 18 months, but are they able to say, pick up a item and pretend it's a brush and run it through their hair? These are all little clues to us that let us know, that actually inform language development. Comprehension, how much do they understand? Are they able to imitate? And what kind of communicative intentions do they use? So they might not have language, but anybody who's been around a baby knows they know how to protest. So are they able to request? Are they able to comment? Are they able to protest? And what's the diversity of these things? So when we look at some of the red flags for impairment, definitely the one I mentioned earlier, this 10 months canonical babbling stage. If we're not hearing those babbling sounds at about 10 months, that can be a red flag and something that we'll watch. So not only that, but we look at the rate of their vocalization. So how often are they vocalizing? Also, what's the ratio of their consonant to vowel sounds? Do they still have a predominantly vowel-based sound inventory? That can be a problem as well. Gestures, there's some research indicating that they can be a prognostic indicator for language development. So how are they using those gestures? Like I said, comprehension, if babies are understanding that less than about 3 to 50 words by about 8 to 12 months. I know that's a huge bucket, but if their comprehension is very limited, that's concerning. Imitation, do they have very few spontaneous imitations? So say, for instance, we've got our little baby here on the right of the screen playing with his car. If you're a caregiver playing with the baby, you might use the car and talk about the car, repeat car over and over, or the blue car is going fast. Eventually, in a typically developing baby, they'll start to imitate you, whether that's just saying ka, ka, or eventually saying car, blue car, moving on. So that would be typical, but in an atypical baby, they may never imitate. I'm a parent, I have children, and I know I think most parents have a story like this where you're driving in the car and something really scary happens and an unintended expletive comes out of your mouth. And lo and behold, there's the little, 14-month-old in the back seat who is now repeating verbatim everything they just heard. So while it's not the vocabulary you intended to teach, that spontaneous imitation of words is good. That's what we want to see. So if they're not doing it, then that can be concerning. And then those communicative acts I mentioned, requesting, commenting, protesting, we should be seeing on average about 2.5 per minute of free play. So if they are doing less than that, that can be concerning as well. And they may have just a less diverse inventory of intentions. So maybe all they do is protest, and that could be concerning as well. So there are certain risk factors that put infants in a position where they could be at greater risk for communication disorders. So some things we might know even prenatally, hopefully we know prenatally would be Down syndrome or cleft palate. Hopefully deaf or hard of hearing, we might know after the newborn hearing screening, after they're born. Sometimes those things don't show up until later. Other syndromes can sometimes be hard to identify, so we may not know until later as well. But there are also certain prenatal, perinatal, and neonatal risk factors, and I don't want to get in the weeds with those, but I've described them in the notes in the PowerPoint, so you can look at that. But prenatal is anything that happens in the womb. Perinatal is anything that happens during birth, and neonatal is anything that happens immediately after birth. So a important component of really, of course, working with any client in language impairment is getting the case history, but especially with infants and toddlers and preschoolers, we definitely want to get that birth history and know, were there any complications during the pregnancy, any during birth, were there any problems immediately following birth? Because if children have 2 or more of some of these risk factors, there's a study cited in your text, that they can be more likely to be diagnosed with language impairment in later on. So these are important things to know, kind of add to our picture of what's going on. So moving on to toddler language development. So, I didn't even mention, but back in those baby slides, I do have some really good examples of infant vocalization development. So go in the notes and look at some of those videos. They're kind of fun. I think one is actually on the vocalization stages slide. So take a look at that one. That'll give you a good example and a good explanation of babbling. So take a look at those and you'll get a feel for what I'm talking about. Moving on toddler language development, in the PowerPoint, I have some good videos here as well, some really cute examples of toddler language development. So around the 1 to 1.5 years of age, we see the one-word stage happening. And then somewhere around 18 months, again, like I said, it's a big bucket, could be a little before or after. Once they've gained about 50 words in their vocabulary. So up to that 50 words, we've seen kind of this slow but steady vocabulary growth. But once they hit about that 50 word mark, it seems like just exponential growth in vocabulary. We call this the word spurt. They start to understand that a single word can have multiple communicative functions, like shoo. It could be a protest. It could be a question. Or a request for help. So they begin to understand that. And then around 2 years of age, we start to see 2-word combinations develop, and early syntactic development and understanding of how words relate to each other, semantic relations. So action words, object words, possessor and possession, my car, right? Toddlers definitely get rules of ownership. So things that we might see in toddler language impairment would be this limited receptive and or expressive vocabulary, delays in word combinations. So this is kind of a common time for parents to start noticing that something might be wrong because they may have a few words in their vocabulary, but they're not combining them now like maybe their peers are. Limited use of those semantic relations. So maybe they use only one of those semantic relations, but don't broaden into different kinds of relations. Less initiation of conversation and fewer communicative intentions with single words. So for example, I have in the notes, I believe, an example of the word daddy. So a typically developing child might use the word daddy to request, to ask daddy to do something, daddy. They might use it to protest daddy when he's driving them nuts, daddy. They might use it when they're surprised to see daddy, daddy. Whereas a child with atypical language development may never use that word until prompted by, say, mom, who says, "Who's this?" pointing to daddy, and then then the child produces the words. So those are some differences we can see in language impairment in toddlers. So moving on to preschool, very rapid growth in phonology, morphology, and syntax. Oh, and before I forget, there's some really fun language samples of preschoolers. My favorite is the one where they're arguing about whether it's sprinkling or raining. Watch it, it's so cute. By age 3, they should be about 75% intelligible to the unfamiliar listener. By age 4, about 100% intelligible. Did I say unintelligible? 100% intelligible to the unfamiliar listener. They'll begin using a broader range of morphology. They'll use questions, clauses, understand some of these WH questions. They'll have vocabulary for basic concepts, use a variety of word classes. Some social aspects of language. They'll learn how to make requests, comments, they initiate, they maintain, select, and change topics of conversation. So looking at this list, you can kind of break this down again to those components of language that we talked about. So here we're kind of talking about form, right? So what we see in form. Here we're seeing what should be present in terms of content, vocabulary, and the way words relate. And then in the social aspects or the pragmatics. So you can kind of see where we break down these impairments and look at strengths and weaknesses in each of these components. So in preschoolers with language impairment, this might be some of the things we see, of course, not all inclusive, but difficulty understanding conversational rules, right? A pragmatic problem. They might not initiate or respond to language. Limited topic range for conversation, again, a pragmatic problem. They might use a lot of non-specific words like thing or stuff to compensate for a very small vocabulary. So their semantics might be, the content of their language might be limited. Trouble comprehending basic concept words. They might favor very simple sentence structures over more complicated ones. So a preschooler might say, the boy watched TV, when a typically developing peer might say, my cousin Charlie watched cartoons on TV yesterday. So that sort of thing. And maybe limited use of grammatical morphemes or incorrect use of them. He jumping as opposed to he is jumping. So those are some of the patterns that we might see. So moving on to school age, I don't think I actually have many examples in these. I suck with the younger kids. But school age language, they may still be acquiring phonology. They'll start using advanced morphological structures, rapid growth in complex sentence structure, rapid vocabulary growth. So again, you can kind of look at this list and break it down. What's form? What's content? What's use? They understand that words have multiple meanings. So this is a form issue, semantics. So take the word bear. Think for a minute, you could pause the video and think of how many different meanings of the word bear you can come up with. So just a few off the top of my head are bear as in bearing a burden, something's a heavy load. Bear as in the noun referring to the animal, the big fuzzy thing that's going to eat you when you go into the woods. um, and then there's also maybe the way we use it to describe someone. He's a real bear, somebody who's really difficult to work with. Figurative language, idioms, those things become part of their language. Storytelling, narrative instruction, inferences, jokes, riddles, language for social bonds. The pragmatic piece of language expands in school age. So this is what we might see in impairment: limited vocabulary size, difficulty learning simple and complex vocabulary, inability to understand the multiple meanings of words. So for instance, if a child hears the sentence, "The noise of the fans disturbed the boy." Well, if their only understanding of the word fans is the literal object, a fan that, spins overhead or on a stand in your room, if that's the only concept they have of fans, they may not understand what someone's saying when they're using that word in the context of, say, people cheering a sports event, right? Fans, the noise of the fans in the stadium disturb the boy. So if they don't get those multiple meanings, they might miss the intended meaning of a sentence. Figurative language will be difficult. Less complex sentence structures might be used. Social language challenges, so issues with pragmatics. Reading comprehension, decoding issues, so problems in the written component or written modalities of language. Impaired narrative structure, they may have difficulty telling a story, and problems with writing. So moving on, we're going to talk a little bit about some of the diagnostic conditions of language impairment. So you're going to talk about some of these. I'm going to talk about a few of them that I don't think you talk about in any other lectures. So not comprehensive by any means. You will get a lot more of this later on, but just kind of a little overview. So the first one to start with is developmental language disorders. And this, the first piece of DLD is primary developmental language disorders. So that is where the language disorder is the primary issue. It's not secondary to any other existing conditions like intellectual disability, autism, etc. The problem with, with this one is that it does go by a few names, which can be a little bit confusing. So in some research articles, some researchers, some clinicians, some textbooks, and still the NIH, they will call it specific language impairment. And I believe in a lot of schools, they might still call it this, although the diagnostic label used in the schools is different. Anyway, so you might hear it called specific language impairment. ASHA refers to it as spoken language disorders. The DSM-5 that doctors use calls it language disorder in general. The IDEA, which is the law that's used to break down diagnostic conditions that can be used to qualify children for services in the schools, they call it speech or language impairment. So lots of different names, but kind of referring to some of the same characteristics. One thing I will note is that it's important to be aware of what the definition for this is, say, in a research article that you're reading. Sometimes researchers will use exclusionary characteristics in their definition. So SLI might only be defined by a certain nonverbal IQ range, something like that. So bottom line, just read the fine print when you're looking at research and be sure you understand the inclusionary and exclusionary context of their definition. So done. Anyway, moving on. Primary DLD can also coexist with literacy disorders, for example, dyslexia. It's not uncommon for some sort of written aspect of language to be affected, although it can be unaffected. It just depends. And then you've got developmental language disorders that are associated with or secondary to existing developmental disorders, such as intellectual disability or sensory impairments like hearing and vision loss, TBI, seizure disorders, psychiatric disorders like ASD or attention deficit hyperactivity disorder, or also extreme environmental disadvantage. So things like fetal alcohol syndrome or extreme malnutrition can also be associated with language problems later on. So starting off with primary DLD, maybe also known as SLI, here are some of the characteristics that we might see. Again, every child is different, but some of the things that we might see kind of broken down into areas here vocabulary-wise. So content might have delayed vocabulary. They often require multiple exposures to a word before they learn it. They might, again, use that non-specific vocabulary thing. They might have difficulties with lexical retrieval. So some children will demonstrate what we call circumlocutions. That's where they'll kind of talk around the word to help people understand what they're trying to say. So in this example, I gave you this young boy was trying to explain that he wanted an English muffin for breakfast, but he couldn't think of the word. So he described it as something round and English. So this is also a strategy that therapists can use to help children when they can't quite find the words they're looking for. Morphosyntax, they might have limited sentence structures. They may or may not have equal deficits in comprehension. It really depends. Fewer grammatical morphemes, more likely to delete them or misuse them, and also misuse of pronouns. Pragmatics, they might be passive in conversations because they don't feel comfortable or don't understand. Trouble presenting, speaking publicly, social language deficits. So they might have difficulty with some of these more nuanced aspects of language like indirect requests. So for instance, I have an example of two kids at preschool here, and one of them's eating a yummy snack, but he has a developmental language disorder, and one of his peers comes to him and says, "Your snack looks good." And for someone who's a little more savvy and aware of that nuanced piece of language, they might understand that that's also an indirect request and say, "Yeah, it is really good. Do you want some?" But in this case, the child with a language impairment just took it literally and said, "Yeah, it is really good." So some of those more nuanced aspects of language will be difficult for them. There's also specific learning disorder. Now, this is language impairment that's specific to a particular academic skill. So they might have specific issues with word decoding, reading comprehension, writing, number facts, and reasoning. They'll function substantially below the normal range for their peers. It's not secondary to any other disabilities or disorders, so this is the only problem that they have. And it can possibly co-occur with a primary developmental language disorder. An example of this, of course, is dyslexia. And this is specific problems with phonological awareness, spelling, decoding, and also some sequencing tasks, interestingly. Typically, a lot of times these children will have very good comprehension in oral language, but again, where their impairment manifests is when you put a written language task like reading in front of them. That's where it shows up. So again, kind of making that distinction between the modalities of language and describing their strengths and weaknesses. So you're going to talk about hearing and vision loss. I think you're going to talk about ASD. So I picked out intellectual disability to kind of talk a little bit about the language characteristics there. So an intellectual disability, the definition of that is that there are two components: significant limitations in both intellectual functioning and adaptive behaviors. And this can come from a variety of causes. I think one of the more predominant ones is genetic conditions, and that could be Down syndrome, things like Fragile X, Williams syndrome. The more common that you've probably heard of is Down syndrome. And this is a little snapshot of some of the things you might see in language impairment in children with Down syndrome. They'll have again, it's all it's all dependent on the child. So I can kind of say it might look like this. I can't say for sure it'll look like this. Um, Typically, they can have a more typical pattern of acquisition. It just happens delayed at a later time frame. So rather than first words at 1 year, it might be more like 3 to 4 years. So it's delayed more than deviant. The same pattern of acquisition occurs just at a later time frame. Their vocabulary can be possibly aided by bimodal input, so using both sign and oral language can help them with vocabulary acquisition. They'll have delays in syntactic development, likely to omit function words and verbs. Expressive language skills will often lag behind comprehension. Um, and atypical phonological development can be a component of this. Macroglossia is enlarged tongue. That's just one of the pieces that happens in Down syndrome, and that can interfere with articulation. Also, low muscle tone is a characteristic of Down syndrome, and that can also make articulation challenging. Some children with Down syndrome will have pragmatic skills that are largely intact. I put the little asterisks there, of course, because it just depends. But particularly when Down syndrome and ASD co-occur, that's where the pragmatic skills will also be compromised. But in the notes, I do have a couple of good videos here. One that's a sample of a child that kind of shows some of the articulation problems that come with macroglossia. And you'll hear the mom cue him or praise him for keeping his tongue in his mouth. And the second one is really cute. It's a pair of brothers, Griffin and Turner, I believe, and it just a little sample of language between a boy with Down syndrome and his brother. It's really cute. Okay, so assessment and intervention. So once we suspect a language disorder, we move into assessment, and that can happen any number of different ways. So we may use standardized assessments. These can be norm referenced or criterion referenced. Norm referenced are where we take a large sample of a similar population to the child that we're hoping to evaluate. A large sample of their peers and kind of look at how they do on these certain tasks, and then we compare the child to how they functioned relative to their peers. Did they kind of fall in the middle of that distribution? Are they lagging behind? Are they ahead? So these standardized assessments have been set up so that we can make age-based comparisons to children's peers and see where their strengths and weaknesses might lie. Standardized assessments are helpful. They're good for qualifying for services, but they don't necessarily give us the whole picture. So we will do more than that, but they do have a place. Criterion reference measures are looking at one particular component of language, say reading, like reading rate, how quickly they read. Those are helpful for establishing a baseline of function at a specific skill, and then you use them to retest after intervention has been applied to see whether they're making progress. Authentic assessments. So those are things like observations, language samples, how they actually use language in real life contexts. Those are really important to describing what's going on. So we use those as well. Dynamic assessments, and this is where this gives us information on what kind of teaching modes will be helpful to the child. So we may test them on a specific skill, then teach them in a specific way on that skill, and then test them again to see whether that teaching mode worked. And then also for children with very complicated needs, we may do interdisciplinary assessments involving, say, occupational therapy or physical therapy, because speech will kind of overlap, speech and language will overlap with some of these things. So I have pictures here. If we were in class together, I would love to bring one of these and kind of show it to you and maybe have you do a piece together. This one up here, the Self-5, that is typically used with older children. I have the age ranges down in the notes, you can see, but this is a good one for, say, elementary school age. The MacArthur-Bates Communication Developmental Inventories, the CDI, that is a questionnaire that's good to use for parents, particularly with younger children, since they don't have language, so parents can be a good partner in doing that assessment. The PLS-5, I just wanted to point this one out because it kind of shows some of the challenges of working with our younger kids. So this is particularly good for young children, preschoolers. And it's great because it has toys in it. So assessment as play. This is very important for that younger population. So, okay, so this is a little activity that I would love for you to do. You can pause the video and do it now, or you can do it at the end. But reflecting back on everything we've talked about, typical and atypical language in children, think about in each of these stages of growth and development, first, what we would assess, what would we look at, what's important, what are some of those milestones that we talked about, or what would we expect to see, what would be important to look at and make sure they've got skills in. And then also think about what would be the challenges. What are the challenges of assessing an infant or a toddler? What are the challenges of assessing a preschooler and a school-age child? I'm 100% sure you're already thinking of some. These can be child-based challenges. It can be environmental-based challenges, such as not having a distraction-free area to assess a preschool child. That could be a real big problem. Or maybe the school that you're working at with a school-age child doesn't have quite the perfect assessment that you need to look at this one particular issue, but you've just got to make do with what you've got. Or you could have parent-related challenges. Maybe they're in denial. They don't want to have their child assessed. That can happen in the school-age population or younger. So take a look. I did provide answers to all of this in the notes in the PowerPoint, but it would be great for you to, good opportunity for you to learn, to go back in to the PowerPoint slides and kind of see if you can generate one or two ideas for each of these things. But I do want to point out right here, assessment should always, as often as possible, be non-biased. And that is difficult, but we need to do our very best. So they should be culturally and linguistically appropriate measures. So if the standardized tests that we have on hand are not reflective of the population we're assessing, it will be a better way to assess them using more authentic measures, such as observations, language samples, etc. Standardized measures you should really always be sure that the population that those standardized tests are normed on fit the population that you are actually assessing. And you can always find that in the examiner's manuals in these standardized tests, like the ones I showed you on the previous slides. So try as best as you can to be sure that these are reflective of the children that you're measuring. So an example, a reason why we might want to do that, for instance, is if a child speaks African American English dialect, then there are certain grammatical constructions that are acceptable and rule-based in that dialect that might show up as errors and give you in a standardized measure that they are disordered. Well, actually, it's not a disorder. It's just a dialectal variation. It's what we call a difference, not a disorder. So we want to be sure that we're using appropriate measures that don't misidentify what's going on. Okay, so last of all, intervention. Good intervention is based on good assessment. It is a garbage in, garbage out model, right? So if we have a garbage assessment, we're going to have garbage intervention. So we want to be sure we are basing our intervention on really good assessment. Once you've done assessment, you've got a better picture of what's going on. That's when we implement our evidence-based practice. So that begins with framing our clinical question. So that will be looking at what is the particular issue or problem with the child and moving forward from there. So step one is frame that clinical question. What's going on? What are you trying to address? Next step is find the evidence for that. Do a lot of research. Gather all the relevant evidence to what you're looking for. Third, assess that evidence. Is it quality? Is it good quality research? Does it meet those standards for good quality research that you're going to learn lots and lots about in your program? Also, is it relevant to the particular child you're working with? So same socioeconomic factors, etc. Like, will those results apply to this child that you're working with? And then last of all, you're able to make your clinical decision based on all of this. So here's my little model of evidence-based practice. It's always based on good external scientific evidence, but it also takes into account client perspectives and clinical expertise. So say you come up with these, 3 different methods of intervention. You can bring them to the client and say, here are some of my thoughts. Here are some of the things we can do to address this, and get their perspective on it. What will work for them? What do they think will be effective for them? And then we also include our clinical expertise in that decision. So in the example I gave of maybe the 3 modes of intervention, maybe you're good at 2 of those, but you know very little about the third. So you would want to maybe look more into using those 2 that you are more familiar with, or apply that third one when you do have the training for it. So factor in your own clinical expertise into good evidence-based practice as well. And then also in that case, maybe where the client wants the one that you're not particularly good at, step up and refer, give them the information they need to go find a clinician who maybe could give them that intervention and be skilled at it. Okay, last of all, just real quick mention, because you're going to see this later on, 2 different acts that apply to intervention with children. Section 504, which prohibits discrimination against individuals with disabilities and agencies that are receiving federal funds, so schools. That provides for accommodations, so they have equal access to curriculum and such. The IDEA, the Individuals with Disabilities Education Act, this is describes identifying and providing intervention services for children ages birth through 21. So I want to point you kind of get your attention here with these 2 bottom things. If you ever have somebody approach you as you're just going through your communication disorders degree, it will probably happen. They'll come to you and say, my child is doing this. So if you ever meet somebody who has questioned their child and they want to get answers, I want to be able to give you the information to point them in the right direction. So if that child is ages birth to 2 months, 2 years, 11 months, so right before their 3rd birthday. If they're in that 0 to 3-year-old range, then we refer them to AZIP, and that's Arizona's Early Intervention Program. And I put the link there. Anybody can have an evaluation by AZIP, whether they qualify for services, that depends on the evaluation. And then if the child is over the age of, if it's 3 or older, 3 to 21, that's when we use the IEP plan in the schools. So that assessment and evaluation would be through their local school. So you can refer them to their local elementary school or high school, and they will be responsible for providing assessment and identifying whether that child qualifies for services. So anyway, if you have any questions, I am here to answer them. You have any questions about the master's program, I'm happy to answer those too, not just this lecture. So thank you for listening. And that's it.